So very warm welcome to our latest edition, in fact, the holiday season edition of our EuroELSO Webinar series. Thank you very much for joining today. In fact, we have the highest number of pre-registrations for this webinar in adult patients. And thank you very much for supporting us with this format. And this really motivates us and keeps us further developing it in the future. Thank you so much for being here today. Now, before I introduce our speaker, I would like to remind you that during all of the times of the presentation and even thereafter, you're able to enter your questions in the webinar tool. And after the presentation, I will forward the question to our speaker so we can have a nice discussion. My name is Peter Schellongowski, and I'm the moderator today from Vienna, Austria. And it's a special occasion today for all of us to listen to our president of EuroELSO, Jan Bělohlávek, who is a renowned ECMologist, not only but specifically in the field of ECPR. Jan, thank you very much for being here today. We've had you a while ago on the same topic. So today we have an update, and I'm really excited because I'm hearing that you will also share some new data from the out-of-hospital cardiac arrest Prague study. So thank you once again for being here, and we are very much excited to listen to your presentation.
Peter, thank you very much. My great pleasure and honor, and I'm very glad that this topic is as attractive as I expected, actually, because this is the most probably the most attractive part of ECMO we are doing. So, and many centers are trying to do ECPR, and therefore I decided to give a little bit more wide perspective for what we are doing. So, and I also am going to share with you some new data which we could not talk about the last time. This is my disclosures. From the wider perspective, if we look into the cardiac arrest, this is a EuroELSO study performed in October 2014. It was a cross-sectional study, nicely showing what percentage of patients is being hospitalized and admitted to hospital with ROSC, and patients who are admitted under ongoing CPR. This is those bright green bars, and what you can see here is that it's very heterogeneous. So there is some countries in Europe using a approach of admitting patients under ongoing CPR. There is others who don't perform this. And this is the overall numbers from the study. As you know, it's been more than 10,000 EMS attended out-of-hospital cardiac arrest cases in 27 countries. 66% was an average bystander CPR percentage. Only 22% of patients had an initial rhythm of ventricular fibrillation. 25% of patients who were brought to hospital had ROSC, and those patients overall had 10.3% hospital survival. You can see the survival was different in different countries in Europe. So at least from this study, we see that the practice worldwide, or at least in Europe, is pretty heterogeneous. So, and it depends on local practices and on local preferences, and in terms of logistics, and also in terms of survival. The other thing is that after proving and having known for many years that invasive assessment and treatment by PCI in STEMIs, which is the most important part and the most frequent part of a cause of cardiac arrest and of presumed cardiac etiology. So probably we are living in a world that we think and we assume that specialized care in cardiac arrest centers may increase neurological survival. And this is data confirming that if the patient is admitted to invasive heart center, probably the survival, due to many reasons, is going to be much better. And this is based on more than 25,000 people. So what is important to say that we are centralizing our care, we are specializing our care, we are providing the top care with many interventions. However, with some of the interventions, sometimes trying to improve the outcome, maybe we delay some important interventions, which may not look so attractive. And this is a story of hypothermia, or if you like, target temperature management. As you all know, and Peter is from Vienna, so one of the first randomized trials, the Cath trial from Fritz Sterz from Vienna, has shown the benefit of hypothermia in patients with cardiac arrest and ROSC. And then later in 2013, the TTM1 trial came, showing that the problem is probably much more complex, showing that a routine using of 33 versus 36 did not provide any difference in the outcome. What is important to say that 50% of cases which were brought to hospital basically had a favorable neurological outcome. However, the hypothermia, which was at that time in the guidelines recommended, didn't show the benefit. And the reason might probably the 5 to 6 hours time from randomization to reaching target temperature. And a similar story and the criticism was for TTM2 trial, and the same, that if it takes 5 to 6 hours to reach a target temperature, we probably cannot expect any favorable influence of the outcome by hypothermia. And this is important because if you look at the catheterization studies, and this is the COACT study, and there is another recent Tomahawk study, has shown the similar in cases which were without ST elevations. Both of those studies show that immediate invasive assessment doesn't make any difference in the outcome. But I'm showing this study because of this number. The median time to reach target temperature in patients randomized into the COACT trial was 5.4 hours. So what I'm saying is that sometimes if we use some interventions which we presume to be valuable for a patient, like invasive assessment and treatment, we may lose a potential for other treatments like hypothermia, which might actually help the patient to survive with a good neurological outcome. Back to ECMO. ECMO has become a most widely used mechanical support around the world from several reasons. H1N1, 2009 to 2010 started, then the failed German study with balloon pumping at 2012, and now probably after 2021 with COVID, we'll have thousands of patients being treated by ECMO. And the widespread of VIVA ECMO due to COVID, of course, opens the era for using VA ECMO for cardiac cases and also for ECPR. So I'm quite sure that ECPR, based on the widespread use of ECMO, will become a probably standard of care. Whether this should happen or not, we're going to discuss later. So we will discuss different kind of cardiac arrest in comparison to studies I have shown. Those studies were where patients were randomized after return of spontaneous circulation. We are discussing patients who do not achieve return of spontaneous circulation, ROSC, and those patients have a very poor prognosis. We know this for years. This is one of the analyses from the United States. You see patients being professionally resuscitated for 15 minutes. Their chance for survival goes below 5%, somewhere around 2%. This is a large Swedish registry showing how the number of defibrillations needed for conversion of a patient to sinus means potential survival. So if you go over 4 or 5 defibrillations, we are below 15%. With 6 to 7 defibrillations in refractory ventricular fibrillation, we are somewhere around 10%. If we need more, we go even below 10%. So overall survival in truly refractory cardiac arrest cases is very low. And the question is, which patient and when becomes refractory case? This is a Brian Grunow study from Vancouver, more than 1,200 patients, 27% overall survival, so excellent care. Again, showing here the rapidly decreasing chance for survival with time. You see 15 minutes, 10% chance for survival, 30 minutes below 5% of survival. However, this study has nicely shown where is probably the breaking point for thinking about different methods and different ways of transport and treating a patient. Patients in this study reached ROSC, those who survived with normal neurologic outcome in 8th and 24th minute, and this was 50 and 90% of survivors. So if you look at the ROC curve, 16 minutes functional CPR is exactly the time when we should start thinking about different way, because if we don't get ROSC within 5-10 minutes, our chance for survival goes far below 10%. So probably in 16 minutes. But what is important to stress is not too early, not too late. So the patient has to get a chance to get ROSC. So probably 15 minutes of CPR is okay. If the patient doesn't reach ROSC within 15 minutes, we have immediately think about different methods to go on in the next couple of minutes. ECPR is basically easy. It's just a continuation of CPR using mechanical circulatory support. We use VA ECMO as the main device. It's inserted routinely in the cannula into the vein and the return cannula into the artery from the right atrium over pump oxygenator bag. So very simple extracorporeal circulation. This is a patient on the ICU after ECPR. The only difference is that we have to cannulate the patient under chest compressions, and this is how the ECPR is being defined. So it's not a cardiogenic shock patient. Sometimes you can have a cardiac arrest after cardiogenic shock, but ECPR stands for cannulating and connecting a patient to ECMO during ongoing cardiopulmonary resuscitation. Several analyses has shown it works. This is also data you see over 1,700 cases. Increasing numbers in the last years, and almost a steady state of survival. This is a mixed population of in-hospital and out-of-hospital cardiac arrest cases, and pretty reasonable survival in those patients of about 30%. There's been a lot of non-randomized studies showing that this may work, and based on those non-randomized studies, we know exactly that patients who are optimal for ECPR are those who are totally refractory, so who failed conventional CPR to achieve ROSC. So as I said, at least 16 minutes, who don't have any major comorbidities. We prefer witness cardiac arrest either by EMS or public place or in hospital witnessed by the medical personnel. We hope for correctable cause, so mainly for acute coronary syndromes. Shockable rhythms do have a better prognosis in terms of using ECPR, but the other rhythms like PA is probably not contraindicated, and we'll talk about that later if you like. Intermittent ROSC is a wonderful indication for ECPR. It's those patients who got the ROSC for a couple of minutes and then they have another ventricular fibrillation and again. So those patients may benefit from ECPR. And of course, we have to reach the patient shortly. So either with a short transport from the field to hospital, or the reaching time must be reasonable in cases where ECPR is being provided out of hospital and the cannulation is being provided out of hospital. ECPR is one of activities which should not be improvised. So we should train for that the similar way as you can see in the teams which train all the year to be the best. And those teams, if they are able to change the tires and fill the tank within 2 seconds, the same way we have to train ECPR, because ECPR is time dependent, and every minute we lose actually decreases the chance for a patient to survive. So this is one of the possibilities where to perform ECPR. This is our Cath lab, and we are doing this for 10 years almost. So we cannulate patients at the Cath lab from logistic reasons. Other institutions cannulate at the emergency room. Some institutions cannulate at the ICU or cardiac surgery operating room. I think it's important to realize where it's the best for the cannulating team and where is all the devices available. So we think that at the Cath lab, it's a good place to use for cannulation. We have an X-ray, we have an ultrasound, we have, of course, ECMO, we have a ventilator section, we have a Lucas carbon plate to be able to use X-ray during cannulation, and we don't need to use blind puncture and blind wire insertion, which is potentially a cause of possible harm to the patient. Our team usually consists of 5 to 7 people, depends on the daytime. There's always the intensivist taking care for airways, for the overall CPR coordination, interventional cardiologists, 1 or 2, 2 ICU nurses, 2 cath lab nurses, perfusionist, and the data manager to monitor how the CPR proceeds. Very short video just to show how it works. This is a typical case. And honestly, all the cases look the same. Patient's been brought to the cath lab by the emergency service. This is a typical out-of-hospital cardiac arrest scenario. Usually males to 55 years of age, smokers who collapse on the public place, usually 5 to 8 unsuccessful defibrillations for VF, and the time to get on the cath lab table or generally to hospital is usually 45 to 55 minutes after collapse. And whatever we do, it's difficult to reach the short time. You have seen that under mechanical CPR on the table, we got into the vein and artery, connected the patient, and now the diagnostics and potential treatment continues. Of course, we wait for possible occlusions. This is a typical cause of ongoing refractory ischemia, proximal LAD occlusion, and very easy PCI. And this is important that the treatment is easy, but we have to keep the patient perfused to give a chance for a neurological recovery or other organ recovery, and therefore we use ECMO. Originally, before ECMO was available, we used mechanical CPR, but a very minor number of patients survived because the perfusion was not adequate. So at this moment, when we admit a patient under ongoing CPR, we first put the patient on ECMO, and then in a quiet surroundings, we perform diagnostics and eventually PCI. And I could show you many cases, difficult ones like this one with severe multiple organ failure and prolonged weaning from ventilator and rehab, or this case, a lady who's been 1 month waiting for recovery, then switched to LVAD, and then finally transplanted, and other many of patients who were unsuccessful, of course, because most of them die. However, the chance for survival is not negligible. And this is Minneapolis data from the group of Dimitri Pianopoulos comparing ECPR model of the care, randomized study comparing ECMO-treated patients, the blue ones, versus the placebo arm of the amiodarone study. And what you can see nicely is that every time period after 20, 30 minutes, those patients who are treated by CPR do have a better prognosis. Even those who are resuscitated more than 60 minutes still have a very reasonable chance for survival, somewhere between 15 and 25%. And this is good. So every 5th patient is going to survive prolonged CPR. Important to say those patients were patients with initial rhythm of VF, and the system is working perfectly well with short transport times. The same authors published the first randomized study almost exactly a year ago, and this is a RS trial showing a comparison of ECMO treated patients versus standard ACLS group. Those patients were brought to hospital under mechanical CPR to the ER, randomized at the ER after 50 minutes of CPR, and then either they continued in standard CPR or implanted ECMO at the Cath lab. And you see that the ECMO group, 6 patients out of 15 survived versus actually 1 patient who survived in the standard group but died within 3 months, and he had a severe neurological deficit. Data Safety Monitoring Board stopped this study after 30 randomized patients and pronounced the ECMO approach as being beneficial and non-ethical to continue in the study. This is based on 30 patients, and we will compare this to our data a little later. What I'm going to show is that it's not as easy as it might look now. So we could say, okay, it's much better to do ECPR for everybody. Let's do that. However, this study has nicely shown recently comparing ECPR pre-ECPR era versus ECPR era. And this is patients before implementation of a routine ECPR care. You see patients 48 versus 100 patients. And the pre-ECPR era CPC score was 100% of those who survived did have a favorable outcome, and the percentage of 30-day survival was 44%, compared to ECPR era where only 37% of patients survived, which was not different. However, only 81% of cases did have a favorable neurologic outcome. So this is a first sign showing that the routine use of ECPR and changing the system may not bring by itself benefit for patients. This is the other study, again from Brian Grunow from Canada, Vancouver, and this is an analysis of more than 27,000 patients comparing intra-arrest transport versus continued on-scene resuscitation. And those patients who were transported under ongoing resuscitation, so intra-arrest transport, survived only in 4% versus 8.5% in the on-scene resuscitation group, which waited for return of spontaneous circulation, and this was statistically significant. What is important that basically all the subgroups in this study benefited from the on-scene resuscitation. So if we perform high-quality on-scene resuscitations, we're not harming patients. The only exception would be the subgroup of those truly refractory patients down here on the right side, which were resuscitated for more than 30 minutes. So probably there's a value added on top of high-quality CPR provided by ECPR, that those patients who are truly refractory and being resuscitated for such a long time might benefit from intra-arrest transport and possible advanced care by ECPR. So now we are reaching the time to share some data from our study. This is a study called Prague out-of-hospital cardiac arrest study performed by the team of my colleagues for past 7 years, and with a cooperation with the Prague Emergency Service. And it's important to say that logistically, Prague has one dispatch center. The whole area of Prague, which consists of 1.25 million people, is covered by one dispatch center, one emergency service. So the communication is very straightforward in Prague. There is 7 cardiac centers. 3 of them are able to perform ECPR. Our center is performing ECPR on a routine basis, covered almost 24/7, and we have started ECPR program in 2010, and this study has been started in 2013. During the study period, which was 2013 to 2020, so 7 years of study in Prague, there was 4,345 resuscitations. So such a number of patients being screened. Out of them, no-ROSC patients have been 358, and out of those, 264 actually randomized into the study. And we randomized those patients into the bundle of care, which we call hyperinvasive care, meaning intra-arrest transport using mechanical CPR, early ECPR in cases which did not attain ROSC, were admitted under ongoing CPR, and immediate invasive assessment and treatment. So it's a bundle of interventions versus standard of care, so a continued standard CPR on scene waiting for ROSC. And if ROSC was reached, the patient was transported to hospital, and early invasive assessment and treatment was encouraged in those patients. You can see that we during the study period, we actually randomized only 6% of the whole cohort of screened patients, and this is important. This is exactly in line with other studies showing that only about 6% of the patients is eligible for this kind of approach, and there were a couple of studies showing it, like Vienna study and the others, exactly 6 to 7% of those patients. After the randomization, we allocated patients either to hyperinvasive or to the standard arm, and we did have some crossover in both arms. The crossover was low, was 7%, and in the standard arm, actually 11 patients have been crossed over from standard to invasive treatment based on the request of emergency service. And on the other side, 9 patients initially randomized to invasive were crossed back to standard CPR due to comorbidities and clinical status that was not considered to be suitable for further invasive treatment. Concerning our study flow and baseline characteristics, this is a slightly different cohort of patients compared to regular resuscitation studies. You see the patients are almost 10 years younger than regular CPR studies. Over 80% of males, majority of patients with cardiac arrest at the public place. Over 60% of cases were in ventricular fibrillation as an initial rhythm. But we have also randomized patients with asystoles and the PEA, because we started in 2013, and at that time there was not too much data showing that PA patients and asystolic patients should be removed, and we stick to the protocol. So we randomized all those patients. We had a very high baseline bystander CPR percentage. You have seen in the Eureka 1 was 70%. In Europe, generally, in Prague, it's over 80%. Generally, patients randomized to study, as you can see, of course, were selected patients with witnessed cardiac arrest, and more than 97% in both arms did have bystander CPR. Similarly, over 77% of cases has telephone-assisted CPR, which is again important, and it's frequently used in Prague. We randomized patients after 25 minutes of cardiac arrest, so 25 minutes since collapse, so 10 minutes, around 8 to 10 minutes to reach the scene, 15 minutes for CPR, and we're exactly at 25 minutes of our time to randomization, similar to the recommendation of the previously discussed Brian Gurnow study. Intermittent ROSC cases was around 1/3 of the patients. We used epinephrine 5 or 4 milligrams in both arms, and patients had 4 pre-hospital defibrillation for VF in cases with ventricular fibrillation. Basically, all patients in the invasive arm were admitted to hospital, as every effort was used to bring a patient to hospital in this arm, versus only 66% in the standard arm, because the rest of the patients died on the scene. And the most important parameter, actually, to discuss the results of the study and to have an idea what kind of population this was and how this population differed to the PTM population and other studies and other registries, is this: patients in the standard arm were resuscitated for 46 minutes, so truly long, prolonged cardiac arrest, and time of CPR was defined as a time to death, ROSC or ECLS. And in the invasive arm, it was 58%, so very prolonged CPRs in both arms. And you can also see, if we look to the subgroups, patients resuscitated more than 45 minutes, 55% in standard and 73% in the invasive arm. Importantly, despite the fact that the patients have been randomized in the field during ongoing chest massage, 27 patients later during the transport or on admission to hospital reached the ROSC in the invasive arm. 44 patients reached the ROSC in the standard arm. We used TPM in all patients who actually reached the ICU. So it was at the end 70 and 95% in those arms, and the majority of patients have been implanted with ECLS and extracorporeal life support ECMO in the invasive, and those patients implanted in the standard arm were those who crossed over from standard to invasive. Time to ECLS was exactly 61 minutes in the invasive arm, and it took us 12 minutes, the mean time from door to implementation of ECLS. This is our result. The study has been stopped based on the recommendation of the DSMB as we reach the stopping rule predefined in the protocol. And we did not reach the difference in the primary outcome. However, and this difference was statistically not significant, P was 0.09. However, you can see that the patients in the standard arm survived in 22% of cases, and we used a very hard endpoint, survival CBC 1 or 2, so no or mild neurological deficits within 6 months after the cardiac arrest, 22%. And still go back and consider those patients have been resuscitated for 46 minutes on average, versus 31.5% surviving patients in the invasive arm being resuscitated for 58 minutes. And despite the fact this is numerically different, it did not reach the statistical significance. What I want to say and stress here is that in the standard arm, when we designed our protocol paper, we estimated and we expected survival here at around 10%. The reason why we, at the end, had a survival of 22%, we may speculate for what happened, but what happened is that we trained the teams, we improved the primary care, we improved and increased the number of bystander CPR, telephone-assisted CPR over time, we increased the invasive approach, and therefore we actually did have twice higher survival in the standard arm than we expected before we designed the study. Concerning neurological recovery, we had 30 days of neurological recovery in 18 and 31% of cases, and this difference was statistically significant, not for the cardiac recovery. In the post-hoc survival analysis, there was a better survival for the invasive arm after 6 months, as demonstrated by this log-rank test. This is a subgroup analysis, busy slide, but what I want to show you is two important details. This is a subgroup of initial rhythm, shockable rhythm, and look here. This is a chance for survival in this treatment in the invasive arm. For survival is if initial rhythm is ventricular fibrillation. 48.6% patients survived favorably with a ventricular fibrillation. So very high chance for survival. With non-shockable rhythms, so PDAs together with asystole, still 8% of chance for survival in the invasive arm versus 2.5 and versus 33.3. So this is important numbers showing that even in non-shockables, there is still a chance for reasonable survival of almost 8%. And the other is the subgroup of those patients who have been resuscitated for more than 45 minutes, showing here that those patients seemed to benefit from the invasive approach, very similar to the study in JAMA from Brian Buell. If you look to the subgroup analysis based on the time of CPR, this is patients who survived favorably and were resuscitated less than 30 minutes, This is patients resuscitated for 30 to 45 minutes, so no difference, and surviving favorably. And this is patients resuscitated for more than 45 minutes. This is the standard arm patients, and this is invasive arm patients. And notably, 6 patients here in the standard arm who survived CPR of more than 45 minutes, 4 of those were actually those who were crossover from standard to invasive. However, by intention to treat, they are counted here. So, and this is different. If you consider that 4 of those patients actually were treated by the invasive approach, so if we performed a as-treated analysis, we would be 2 versus 24 patients, so even more different. From the crossover group, which was, of course, selected and was based on a very strong request from EMS, 5 of 11 patients who cross over from standard to hyperinvasive arm, they survive 100 days with CPC 1 and 2. And this is information saying if we choose properly, if we pick up those prospective patients, and I'm glad that the crossover is only 7%, then almost 50% of patients actually survived in this crossover group. Let me compare a little bit, just our data and the ARES trial. Concerning number of patients, we had 256 patients randomized. ARES trial has 30 patients. In the invasive arm or ECPR arm, if you say, we had 124 patients, ARES had 15 patients. Age in the invasive arm was 58, 59, so very similar population. Males 82 versus 93. Bystander CPR, almost everybody in our study, 87%. Rhythm, we enrolled all rhythms. Our ARES trial enrolled only ventricular fibrillations. However, VF in our study was in 58% of cases, 100% in ARES trial. Randomization, and this is the major difference between those two studies. We have randomized patients on the scene during the CPR. We were simulating the everyday scene when the EMS crews and maybe the emergency room doctors are deciding whether this kind of patient should be transported or under ongoing CPR to hospital. So we compared 2 different logistics starting at the scene during ongoing CPR. ARES trial picked up those patients who were resuscitated for 50 minutes and on admission to hospital decided whether those patients will be put on ECMO or not. And honestly, if you have a patient and you see the time to randomization was 25 minutes in our study and almost 50 minutes in our trial. So after 50 minutes of unsuccessful CPR, we cannot expect any major benefit from continuation of standard CPR, but we can expect benefit from ECMO. And this is exactly what our trial has shown, that after 50 minutes of unsuccessful CPR, basically no chance with the conventional approach, and we need to go with ECMO. Transport time was longer in our study, 26 over 19 minutes in our trial. Time to ROSC was very similar, 58 versus 59 minutes. So basically, logistically, the time was the same. Survival, and look on the survival. Survival in 180 days in the invasive arm was 31.5% in our study, 43% in the ARES trial in 30 patients. However, if we compare ventricular fibrillation, which were only in 58% of cases, we had almost 50% survival, and then ARES trial had 43%. So very comparable numbers. So what we can say based on those 2 trials, probably we are able with this approach in cardiac arrest cases, which are prolonged for almost 1 hour. In ventricular fibrillation cases, we are able to reach survival of almost 50%, and this is important. So let me conclude that we, not ECLS alone, not just the device, but a comprehensive approach, mainly with a very well-functioning pre-hospital system, high percentage of bystander CPR, telephone-assisted CPR, improved logistics, fast transport, experienced teams, experienced cannulators, including ECLS and urgent cannulation, may have an impact on logistics for out-of-hospital cardiac arrest. So we have a first randomized data. We still need to define proper patients. We probably know it. It's patients with ventricular fibrillations, with shortest cardiac arrest possible, and who failed conventional CPR for at least 16 minutes. And we probably need to replicate the study in a multi-center study. And with this, just let me show that there is a recommendation or position paper from the European Society of Cardiology Acute Cardiovascular Care recommending the out-of-hospital cardiac arrest hub centers, which provide over the regular cardiac arrest centers, which provide all features of theirs plus ECPR and advanced electrophysiological treatment. It's probably that the central large tertiary hospitals should provide an ECPR for a selected number of out-of-hospital cardiac arrest cases. And with this, let me invite you warmly in London next year, 4 to 6 May, where we will have our annual EuroELSO meeting, and we will discuss all this in more detail. Thank you very much for your attention.
Thank you very much, Jan, for your great presentation. And I would like to congratulate you on the great study and the stamina that you had to carry this through for 7 years. Very interesting results. And I would like to start the discussion with the study you just presented. Doesn't that somehow remind us of the EOLIA trial, where we have a predefined protocol, where the predefined primary outcome isn't met? However, a series of secondary outcomes are clearly in favor of the intervention. And then when you would take out the crossover patients and look at the post-hoc analysis that you performed, where you only look at the as per received treatment analysis, then you have a positive sign again. So depending on what your belief about ECPR is, you could also say this is somewhat a positive study in a way. Would you agree with that, even though this may not be scientifically very, very adequate, to put it like that?
Yeah, this is a question I'm receiving quite often. Is we present this study as a negative because we did not reach the primary outcome based on a recent and acknowledged scientific approach of intention to treat analysis. However, we have seen several important signals in what is working. And as you know, and there is probably some reason why this is only the second study at the moment and no other studies randomized have been performed, because to perform such a difficult study, logistically extremely demanding, it's almost not possible. And I'm based on our data, based on different other data, I'm quite sure ECPR works. There's no doubt about that. But to define properly which patients should be or should undergo ECPR, this is more difficult. But as we can discuss the types of statistical analysis, if we perform a different type of analysis here, if we perform as treated or per protocol, it's always positive based on our data. But I have been asked why we can have a crossover, why we crossed over the patients. But everybody who is performing studies like this, and this is exactly the case of EOLIA, if you have a patient who is dying under your hands, 40 years old, is after eight defibrillations and still, actually with signs of life, this is extremely difficult to let the patient die. And we did not do that from ethical reasons. And as you have seen, almost 50% of those cases we crossed over, they survived. So we did good, I think, for the patients, but not for the study.
Yeah. Maybe one more methodological question. Will you perform a Bayesian analysis of the data?
Yes, we did perform. It's not going to be a part of the main publication, but we did perform Bayesian analysis, and it was positive.
Great. Glad to hear that. Now,
but it was post hoc, yeah.
Sure. I mean, you very nicely described what it takes, and you gave us an impression how the Prague system works. You need so many co-workers from different disciplines, and this may be very different depending on the place you work. And I would like to forward a question to you that we discussed the last time when we had the topic on. To you, when colleagues approach you from centers who are not yet doing ECPR and ask you, we would like to establish a system like that, to you, what would be the absolute minimal predispositions in terms of routine interventions that can be performed at the center on a regular basis, even before going into ECPR?
I think first, definitely any center which is trying to start with ECPR or would like to start with ECPR should be a high volume cardiac arrest center. So at least 50 cardiac arrest cases per year, and should be a high volume ECMO center, routinely taking care for VA ECMOs, not only VVs. This VV is extremely simple, but VAs are much more difficult. But if we compare ECPR cases versus regular VA cases, it's even much more difficult. So ECPR, despite the fact it's probably the most attractive part of the ECMO, it's the most difficult part. So I would not recommend to start with ECPR, but you need to train the teams. So you need to train the teams for the logistics. You have to cooperate very well with the EMS, and you have to shorten and improve the logistics. And most importantly, with the ECPR, everything starts. You need to have a good post-CPR care, advanced ICU care, neuroprognostication, neurological care, rehab, palliative care, a lot of radiological methods, etc., etc.
Right. Now, you also very nicely showed that depending on the local situation, ECPR itself may not be a very cleanly defined entity, but as you performed in your study, may also involve an entire bundle, right? So when we work in an ECPR center, or we are about to try to establish such a program, what would be quality indicators or benchmarks that you would recommend for centers to use in order to see how they do?
So you should definitely look at your VA cases and your performance in cardiogenic shock cases, mainly for complications. You should definitely look at your cannulation complications. You should definitely look at your regular cardiac arrest cases, meaning the cases with the ROSC. So you should reach at least 50% of favorable survival. And also look at the neurological outcome. Patients look at the complications, pneumonias, and other complications after regular CPR. And when you have enough patients, because ECPR has to be trained. If you look at the numbers I've shown before, we have approximately 1 case per week. And this is, I think, the minimum, maybe 1 case per 2 weeks. This is a minimum that should be performed. And you also need ICU capacity. And ECPR cases are very demanding for nursing staff. So you have to know that taking care for ECPR case in the initial phase usually takes 2 nurses for the patient, because patients are very unstable at the initial phase.
So I suppose that maybe even before you started the protocol of the study itself, you probably saw a learning curve in your center in terms of outcomes. Is that correct?
Yeah. The learning curve, we actually had a kind of preparation phase for almost 2 years that we were admitting patients under CPR and using mechanical CPR and training fast implementation of ECMO. Definitely, yes.
So we have a lot of questions coming in. Thank you to the audience for the questions for technical aspects. So what's the preferred mode of cannulation? Do you percutaneous or semi cut down? What do you recommend?
We use percutaneous cannulation on the table. I'm kind of old-fashioned, so I start without ultrasound, without anything. If I don't succeed on one side for the neck, for the second groin, I always take ultrasound. use ultrasound. But percutaneous cannulation is very effective. Our success rate is more than 95%.
Okay, that's really something, Jan. Do you use distal perfusion in these patients?
Yeah, we use distal perfusion in all cases.
And you do that secondarily? So you first make sure the cannula.
Yeah, exactly. Compared to cardiogenic shock cases where I always implant the distal perfusion first, and then the cannula. Here you don't have a time for distal perfusion cannulation, so you put in the cannula, and then later, after the case is done, we, as the last thing, we under the ultrasound we cannulate the distal perfusion cannula. Yes.
Okay. Now there's a question on your heparinization or anticoagulation protocol, not only for the regular ECPR, but maybe even when you then go to Cath lab and need to perform PCI. How do you behave in situations like that?
Yeah. Majority of patients actually receive aspirin and heparin pre-hospitally while they are being brought to hospital. If there is a high chance of acute coronary syndrome, so if we are talking about males who are being brought up under ventricular fibrillation, you have no idea what kind of what kind of cause it is, because you cannot do 12-lead ECG, so we don't know. And if the patient is not heparinized, we heparinize, but we use low to moderate doses at the beginning of those patients after very prolonged CPR. And if we have a vessel occlusion, then we use heparin. We basically never use 2B3As, or we are kind of reluctant to use 2B3As. I've seen many bleedings after that. And the first 24 hours, we are very cautious about heparinizing patients. So we usually use like 15 to 20,000 units per 24 hours maximum, sometimes less. But this goes one against another. And if we have a large thrombus burden in coronary arteries, we use Cangrexal as IV to be by epsilon inhibitor.
Okay. Now there's another question regarding the study data you just presented. Do you have an explanation for the different ROSC rates on admission in the two groups?
Yes, of course. Those patients who have been resuscitated on scene, they've been resuscitated for a longer time and trying to reach the ROSC. So majority of them, without reaching ROSC, they simply died. Those patients who were transported to hospital, they reached the ROSC in only 27% of cases, but they still reached the ROSC en route during the transport. What is a subject of one of our post-hoc analysis is to look at those patients why the ROSC was lower actually, and I'm quite sure that during transport, and everybody can imagine that during transport your therapy is not as efficient as when you are on the spot. So you are not defibrillating as often, you are not providing medication as often during the transport. So maybe this is one of the reasons. But still, if you decide to transport the patients at the phase that the patient is in cardiac arrest, you still have a reasonable chance that the patient gets ROSC during the transport.
Right. Now, the next question shows that really this is not about quote unquote only putting an ECMO into these patients. One of our participants wants to know what's the rate of your patients that need any mode of venting, let's say impeller or other methods to decompress the left ventricle on ECMO.
Our study started 2013, and that time we basically didn't have any kind of venting routinely used. We very occasionally used balloon pump. At the moment, in these cases, our number of vented patients was very low, below 10%.
Okay. One of our participants would like to know what's your longest ECPR survival, and I would think that probably goes back to one of the first cases you did, because in principle they can have long-term outcomes. Is that right, Jan?
Yeah, I think if I remember well, our longest case is more than 2 hours, and we have quite a bit of cases over 1 hour or so, and it's actually, this is the main mystery of the ECPR, that at the moment, there is no sign or no marker you could use during the CPR or on admission, which would predict the outcome of the patient. The best predictor is signs of life. So the patient is still evidently alive, is moving or screaming. This is a very good sign. And majority of those patients survived actually while being put on ECMO. And then the reactive pupils are good, but meiosis, mydriasis, pH, lactate doesn't work.
Right. Now, you mentioned that you really need a solid background with ICU beds when you have a program like that. One of our participants asked, what's the average duration on ECMO after ECPR?
It's not so long, actually, it's about 5 days. And the reason is that most of those patients either recover fast or die fast. And the number of those who have a prolonged ECMO stay, it's quite low. So we basically in our institution, we are able to have usually not more than 2 patients on ECPR, ECMO CPR, and of course in this COVID era, we are quite limited because we are a high volume ECMO center, but usually we don't need more patients than 2 at the same moment.
Right. Can you give us an impression of your decannulation strategy in these patients?
Decannulation is pretty similar to the regular VA decannulation. You mean the decannulation or weaning? If it's weaning, it's similar to any other VA. Important point is that interestingly, in those patients after prolonged CPRs, you have to wait for recovery sometimes a couple of days. So don't give up fast in those cases because 2-3 days with a very low pulsatility is quite often in this population. On the other side, when the left ventricle recovers, it's easy to wean. And concerning decannulation, initially we had a lot of patients decannulated surgically, sometimes just manually compressed. Now we use the percutaneous technique to close the groin or surgical approach.
Right. I think we have about time for 3 more questions, Jan. And the first one would be 58 minutes from downtime to start of ECMO is actually quite impressive if you think what has to happen in between. What's your guess? Can it get any faster? And if so, what needed to be done in order to get there?
Yeah, this is a question we have been asking ourselves many times. And I think the most frustrating part of the ECPR is the time when you talk to emergency service, you tell them, okay, come with the patient, bring the patient fast. And then you wait 10, 15, 20, 25, 30 minutes and nothing happens. This is a complete disaster and frustration. And I think the logistics of the transport of the patient to hospital under ongoing support, this is the most important part where it can be shortened. The other parts cannot be shortened too much because it takes you 10 minutes to get on scene. You need to try for at least 10, 15 minutes. And then when the patient comes to hospital, we cannulate to usually below 10 minutes nowadays. And it cannot be fastened too much. So the only part which can be shortened is this one.
Right. The second question would be, did you change anyhow your organ donation program with these patients? Were some of these patients included into that program?
Yeah, sure. We do have a very nice post hoc analysis of our data showing that we markedly increased the number of donor organs for the transplant center.
And then I would like to read this question to you because it's also an outlook of how we can proceed in the future, also scientifically. And obviously the question has been written down by, let's say, a friend of ECPR. He says, we now believe that ECPR works. How would you now design a new multi-center trial as ECPR versus no ECPR may no longer be okay to compare? So would you go for randomization to run up to 15 versus 30 minutes or CPR without ROSC? What are your thoughts on the next steps? And of course, you don't have to agree that the question has been answered if ECPR really works and should be the standard of care right now. So what are the next steps, Jan?
I think the important consideration is that the ECPR works for proper patients. It not works for everybody. So, and it depends on demographics, it depends on logistics, it depends on the system, it depends on how your hospital is outlined, it depends whether you take patient to the ER or to the Cath lab. And so there's many things. So we can either go with the road of selecting proper patients or comparing different systems, whether the patient is suitable for ECPR or not. And there is a lot of effort around the world with the out-of-hospital ECPR approach, which is basically completely different. And the main challenge for us was to keep the service 24/7 at the moment. So the only thing we have changed actually logistically after completing the study is that now we are routinely on call 24/7. We have trained other colleagues to perform CPR, and we are 4 who actually share this on-call service for ECPR in our institution. And this is important to keep a very highly specialized team available 24/7.
All right, Jan. I really would like to congratulate you once more for the great set of data that you provided with a lot of work. Thank you very much for your time and your presentation. I would like to remind all of you about the annual conference May 4th to May 6th, 2022 in London, which is as of now planned as a in-person meeting. And there are still some questions left, Jan, and I hope that I can guide all of these colleagues that they are invited to write you an email if they have some more questions to maybe get the proper answers. So with that, I would like to thank all of our participants for joining. Please stay with EuroELSO. We really like having you and supporting your needs and demands, and we hope we can further meet them. And for now, I would like to remind you that you're only safe if your venous line is blueberry and your arterial line is cherryberry. Thank you so much for joining us today, and goodbye.
Thank you. Goodbye.